Today we're going to talk about local anesthetics. This is a core topic for pharmacology, be it your primary anesthesia exam or MCI or anything, and especially for your day-to-day work life as well. So I divided it into two parts. Usually people take it local anesthetic as a short topic, they run through fast. But what happens is when we see candidates cannot answer local anesthetic, it's very disappointing. So I want to go through this in a basic level, starting from the physiology. Then we go into the pharmacology. How does local anesthetic work? I want you all to understand this very well, so we can go through this slowly. Okay, let's go into it. So today the topic will be local anesthetic part 1. So our content will be, we'll talk intro about the local anesthetic. We'll go into the classification based on their structural group and also based on their duration of action. And then we will go in detail about the mechanism of action. Next, we go into the overview of the PK/PD of the local anesthetic. I'm not going to talk about individual anesthetic. The PK/PD of the local anesthetic are very closely related to their SAR, which is their structural activity relationship. Next would be isomerism, toxicity of LA, and EMLA and adjuvants for LA. So if you want to finish all these in one topic, it will be very overwhelming. So I'm going to do it in two parts. So today we will be talking about the intro, classification, mechanism of action, and PK/PD and structural activity relationship. On next week, we will do isomerism, LA toxicity, a short notes on EMLA and adjuvants. Okay. The ionization and pKa, it's a concept that many people doesn't understand in local anesthetic. And if you don't understand it well, you won't be able to relate the PK/PD as well. So I will concentrate on that more on the next part. So today we're just gonna touch on it, but we're not gonna go into the depth of it. I will discuss that in detail in the second part. Okay, I've shared few common SAQs with you all in the group. Those who attempted, good. So you know where you go wrong and how to answer the questions. So the question that I've shared was define and classify LA, describe the mechanism of action briefly, and list factors affecting potency, onset, and duration of action of LA. So we will discuss today based on these questions. So introduction, the definition of LA. If you go to a Viva, if they ask you, how do you define LA? What is LA? So this is the word that you have to say. Drugs that cause a reversible loss of nociception via action potential conduction blockade at sodium channels. Okay, drugs that cause a reversible loss of nociception via action potential conduction blockade at sodium channel. All these are keywords. Okay, you have to mention is reversible loss of nociception. AP stands for action potential conduction blockade at sodium channels. Okay, so just a brief history. The first local anesthetic discovered was cocaine, which is the ester group. Cocaine is not opioid. It is very sad when asked in Viva what group that cocaine belongs to, people answer opioid. Just because it's a substance of abuse doesn't mean it belongs to opioid. Okay, it is the first LA that is discovered. Then first synthetic LA that is produced is procaine, ester as well, but due to a lot of issues with ester, we moved on to amide. So first medical LA that has been synthesized and used is lignocaine, which is an amide group. So next we go to classification or groups. So how do we groups or classify LA? So classification of local anesthetic can be done in two ways. One based on their structure, second based on their duration of action. So by structure, it is defined, is classified into two, ester and amides. Okay, ester group is procaine, amatocaine, and cocaine. The other two are tetracaine and benzocaine. And amides are the one that commonly used in our medical practice, which is lidocaine, ropivacaine, bupivacaine, prilocaine, dibucaine, which is used in as a test LA to determine your plasma cholinesterase deficiency, and for your mepivacaine. So how do we remember this in exam, or you don't have to mention all in exam. You usually have to mention only one or two example. So for esters, I remember CAP lah. Cocaine is the first one that has been discovered, then amatocaine and procaine. For amides, the easier way to remember, so you don't get confused with which one is ester and amide. Amide group always have double I in their name. So you can see lidocaine have 2I, prilocaine 2I, bupivacaine got 2I, ropivacaine got 2I. Whereas in esters, there's only cane. That's the I is only present in the cane. There's no, the front part doesn't have I. So that's how we remember amides. Okay, amides will have 2I in their name, whereas esters only have 1I. So this is how they've been divided based on their structure. Ester group and amides group. We'll go into the structural ring shortly. Next, another way of classifying is based on duration of action. So mainly in amides, in our clinical practice, we will usually classify it based on action. Traditionally, people say short acting is lignocaine, medium acting is ropivacaine, long acting is bupivacaine. But in some books says lignocaine is medium action actually, and whereas ropi and bupi as long action. You are not wrong to say both. If you can say short is lidocaine, medium is ropivacaine, and long action is bupivacaine, is okay. Because when we compare both ester and amide group, ester group are actually the short action one. That's why they don't put lignocaine as the short action. But when we only consider the amide group, lignocaine will be the short acting one, whereas ropivacaine will be medium, and your long action will be bupivacaine. I hope I'm clear. Okay, next we come to the structure. How do these LAs are classified into two group, ester and amide? It is based on their intermediate linkage. So LAs composed of, structure of LA composed of three components. A lipophilic part, which is an aromatic ring, which is same for both. An hydrophilic part, which is an amine, terminal amine, hydrophilic portion, which is also similar for both group. What differs their group, their structure, is the intermediate chain or intermediate linkage, where there will be an ester linkage or amide linkage. You should be able to write this simple structure in your Viva or in your SAQ if they ask to classify your LA based on your structure. You just have to mention this part, OCOC with this double bond here, and NHCCO with the double bond here, to say which is ester and amide. For aromatic ring and terminal amine, you can simply mention, you don't have to mention the lower part, you can draw just like this also is acceptable. Group that differs is the intermediate linkage. So when you draw, you may draw as simple as this is good, but it will be really good that you can remember this part. Okay, rather than this write as COOR, if you can write this is good. Okay, if you can draw this part, is good. Please memorize this. You don't have to remember the whole structure of a lignocaine or bupivacaine, but you have to know, you should be able to write this simple structure, which is differentiating ester and amide group. Okay, all LAs are weak bases. Okay, and they have high pKa, means their pKa is more than the physiological pH of 7.4. What is pKa? pKa is the pH at which 50% of the substance is ionized, 50% of the substance is not ionized, unionized. Okay. So as their pKa for all the LAs are more than physiological pH, as they are weak bases, at the pH of 7.4, they are present more in ionized portion. So this is what the concept that you have to understand, that I will go in depth in next class when we talk about ionization and pKa. It is differs for acidic and also for bases. Okay, we have to talk about Anderson-Hasselbalch equation to understand this more. So for now, just remember these salient points. Will come into the concept in next class. So comparison of esters and amides. Since these two groups have different intermediate linkage, The structure actually causes a lot of differences in their PK and PD. Here are the few important or salient points that you have to write if they are asked what are the difference between esters and amide without actually going into a specific LA. This is an overall as a group, what are the differences between esters and amide. Esters metabolism is rapid by plasma cholinesterase. Okay, it's an enzymatic metabolism which is rapid by plasma cholinesterases. Whereas for amides, it's by amidases, also enzyme, but it's in hepatic hydrolysis. It is organ dependent, it's in liver. So it's slower. Systemic toxicity by esters are less likely because of their rapid metabolism. Whereas for amides, they tend to accumulate, especially in prolonged infusion. So it can cause systemic toxicity. Allergic reaction is more likely with esters because they produce a metabolite called para-aminobenzoic acid, PABA, which is has an allergic potential. That is one of the most crucial reason why esters are no more used in a medical practice now. But whereas in amides, LA allergy is very rare. Stability in solution, esters are not able to found to be stable in ampule. That is another reason we can't use it. You can't keep it in our medical trolley or anything. It is heat or sunlight, it breaks down in ampule. Whereas amides are very stable chemically, can be stored for a very long time. Onset of action, esters are generally slow, amides is moderate to fast, but depends. But this is onset. When I talk about here, the classification, this is duration. Don't get confused. This is classification based on duration of action, whereas what we are talking here is the onset first, then only we come to the duration. Okay. pKa higher than pH, close to pH. But anyway, all their pH, doesn't matter ester or amide, is still more than 7.4. But amides are closer to the pH, closer to 7.4. That's why they are comparatively faster. Your onset of action of LA are closely related to pKa ionization. So when they are more closer to physiological pH of 7.4, more unionized portion is available to penetrate through exoplasm to elicit their effect. Whereas for esters, since they are even higher, far more deviate from the physiological pH, they present more in ionized portion. So thus their effect is slow. And another one, protein binding, which closely related with their duration of action. For esters, their protein binding is less, that's why their action is shorter. Whereas for amide, their protein binding is generally more, so their action is longer. Okay, these are the salient points that you have to write. Next, we come to mechanism of action. Before we go into the mechanism of action, we need to understand the physiology of action potential at the axonal membrane. So the mechanism of action for LA, when I did a class on pharmacology on pharmacodynamic mechanism of growth, we know the LAs are worked through ligand gated, they are working through voltage gated ion channel. Okay, your drugs can act via receptor mechanism or non-receptor mechanism. When under the non-receptor mechanism, there is a ion channel which is voltage sensitive. Ion channels can be ligand gated ion channels or voltage gated ion channel. The LA works under voltage gated ion channel, not the ligand. Okay, it's voltage gated ion channel. They are working at the voltage gated ion channel. So physiology. So what happens at the axonal membrane? How does the action potential produce and propagated, in which the LA can block and elicit their mechanism? So when you have a axonal membrane, okay, this is the axonal membrane, you have a extracellular fluid and intracellular, the external part and the internal part. This is your cytoplasm. This is your external part. Okay, for axon, we call cytoplasm as a exoplasm. We know extracellularly sodium is more, intracellularly potassium is more. The difference of potassium intra and extra is almost 30 times more inside potassium, whereas sodium is 10 times higher at extracellular. So At rest, okay, what we call as a resting membrane potential, at rest, there will be a negative 70 millivolt of a resting membrane potential at the axon. It means at rest means there is no movements of ion along the channel. At the exoplasm, you have a sodium channel, you have a potassium channel, and you have a, so this is a sodium channel, you have a potassium channel, and you have a sodium potassium ATPase pump. This is an active transport which actively pumps in potassium against the concentration gradient and actively pumps out sodium out against the concentration gradient, pumping out and pumping in, but both are against the concentration gradient. At rest, your potassium channel is slowly can leak your potassium outside, but this does not occur at a very large rate because it opposed by the anionic protein component intracellular as well. It's okay, don't confuse that much. So what I want to talk to you here is, because of the abundance of potassium inside, and there is a differences between the ionic charges across the axonal membrane, the resting membrane potential is around negative 70. Okay, if you look here at this graph, where this is your action potential graph, voltage versus time, that minus 70 is your resting membrane potential of your axonal membrane. Okay, your nerve, peripheral nerve. Okay, so when there will be a small leakage of your potassium, this negative charge will slowly become less negative. Okay, because of the slow leakage of potassium. The higher amount of potassium inside, which accounts for this negative 70 millivolt. When there is a slow leakage, this thing will slowly come down until a threshold of 50 millivolt, negative 50 millivolt. At negative 50 millivolt is your depolarization occurs. Okay, this is your stimulus. And if whatever the stimulus or impulse that come to the axonal membrane can cause ionic differences which brings down minus 70 to minus 50, a depolarization will occur in which the voltage gated sodium channel will open. Voltage gated sodium channel open, and then more sodium will comes in. Okay, when more sodium comes in, the membrane potential will be positive. It will reach up to a positive of plus 30 or 40, at which the voltage gated sodium channel will close and repolarization occur, where potassium is efflux to bring back the voltage membrane potential to the minus 70. Okay, this is what. So this resting membrane potential is due to differential concentration of sodium and potassium. So what is voltage gated sodium channel? A lot of people confused about this because when they read some books mention about activated state, inactivated state, rest states and everything. For us to understand that, we have to go in depth about the voltage gated sodium channel. So this is your voltage gated sodium channel. This is your extracellular part. This is your intracellular part. At the extracellular part, this voltage gated sodium channel has a gate called activation gate, which is at extracellular. Whereas at the intracellular, at the cytoplasmic side, it has a gate called inactivation gate. Okay, understand? Extracellular part is the activation gate. Intracellular part is the inactivation gate. So the voltage gated sodium channel as an activation gate and also an inactivation gate. Okay, the activation gate is at the extracellular component and the inactivation gate is the intracellular component. So what happens during the resting state of the voltage gated sodium channel, activated state and inactivated state? So this voltage gated sodium channel can exist in three states. First, at the resting state, second, activated state, and third is inactivated state. Okay, they can exist in three different states. Okay, resting, activated, and inactivated. So what happened to this activation and inactivation gate during these different states? At the resting state, the activation gate is closed, the extracellular part, but the inactivation gate is open. the sodium cannot comes in. Okay, they are closed. Okay, at resting state, the voltage gated sodium channel is closed but capable of opening at minus 70 millivolt. Means if there is a enough impulse that's strong enough to bring down the minus 70 to minus 50, they will depolarize and they will open this activation gate. So that is the resting state. At resting state, the channel is closed but capable of opening. Okay, next, at the activated state, if the impulse is strong enough to bring down minus 70 to minus 50, depolarization will occur and the channel will activation gate on the extracellular part will open and sodium will influx in, and this part is activated state of the sodium channel where both activation gate and inactivation gates are open. They are open and activated. It means sodium influx is occurring. Next, once it already reached a surge of 30 to 40 positive millivolt and there is no more influx of sodium, repolarization start where potassium efflux on it. At this part, from activated state, unless there is a second impulse comes in, there is no impulse, the depolarization ceases and the channel goes from activated state to inactivated state where the inactivation gate closed. Remember the name. At inactivated state, inactivation gate closes, but the activation gate is still open because of the residual impulse and the nerve conduction, but the sodium cannot come inside. Okay, the inactivated. So the difference between resting and inactivated is at resting, at both resting and inactivated, there is no sodium influx, there is no sodium movement, but at resting, they are closed but capable of opening, whereas in inactivated state, they are closed and not capable of opening. Okay, this is the time from positive 30 when it's coming down to reach the minus 70 millivolt of resting membrane potential. So this is the simplified version of explaining what is voltage gated sodium channel. Because when we talk about LA, some books will mention their blockade is more towards activated and inactivated gate. They cannot block the resting. So some people get confused. So that's why I want to explain this in detail. So again, re-explaining on this based on this graph. So we look at the resting state first. At resting state, your inactivation gate is open interiorly. Your activation gate is closed. Okay. Sodium, as I mentioned, it can slowly leak out. Next, we can see when there is a depolarization from 1, it reaches minus 50 and depolarizing phase number 2. During this phase, when the channel is get activated, both activation gate and inactivation gate opens and sodium comes in. Okay, sodium comes in. When it reaches around 30 to 40, repolarization phase starts where the channel goes into inactivated state where inactivation gate closes but activation gate is still open but the sodium still cannot come in. Okay. Finally, from repolarization phase, if there is no overshoot, there is no over efflux of potassium, from repolarization, it will go to resting state. Unless there is too much efflux of potassium, it will go into a undershoot where at this point, both will be closed. Okay, at undershoot, both will be closed, but for our LA topic, you don't have to know this part. Okay, just remember 1, 2, and 3, and from 3, it coming back to 1. So when we look at action potential, so the graph is because of the conductance. Okay, this is the action potential. The first one, the yellow I draw. This is the action potential graph which mimics this. So what happens? The conductance of ions and potassium differs. That gives the graph of the action potential. So during the depolarization phase, the sodium conduction is high, and then during repolarization, sodium conduction comes down, whereas during the repolarization, potassium conduction will slowly increase and then later on come down. So how do we relate these to the voltage gated sodium channel? From minus 70 until the threshold reaches a threshold potential of minus 50, there will be depolarization. So this part is your activated state. At this part, your channel will get activated. Okay, so your activation gate and inactivation gate both open. So just at this part, sodium will go in, and at this part will be inactivated, where your inactivation gate closed, so no more sodium can go in. And finally, this part is your rest or deactivated state, where it is your activation gate is closed but inactivation gate is open. Okay, but it is capable of reopening. It means this is your refractory period. What I wanted to tell you is this is your refractory period where no second conduction can occur, because at this part the inactivation gate is closed, means they are at inactivated state, they are not capable of opening. But at this part, they are capable of opening. Some book mention a resting state, some book says a deactivated is the same. Okay, so the mechanism of action. Now we come to the LA's mechanism of action. LA mechanism of action got two theory. The first theory is the one that I mentioned, the sodium channel blockade. The second one is membrane expansion theory. The first theory in exam, what you have to answer is, you have to mention this keyword. The unionized lipid soluble form of LA will cross the phospholipid membrane. This is the phospholipid membrane. This is extracellular. This is intracellular. This is your cytoplasm. So when you inject your LA topically, you inject your LA at the skin. From here, from the external part, it is the lipid soluble form. Okay, unionized form, which is lipid soluble, will diffuse through the cell membrane to reach your exoplasm, the cytoplasm. Okay, in the cytoplasm, it get protonated or it get ionized. Only the ionized form of the LA can cause the channel blockade. So the ionized form binds to the internal surface of the voltage gated sodium channel. They are not coming and binding here. This is not like muscle relaxant. You give LA, LA goes straight away block this channel at the outer part. No. LA, you have to mention this keyword. Unionized form, lipid soluble unionized form, diffuse through the phospholipid membrane. At the cytoplasm, they get protonated or ionized, and the ionized form, the LA, will bind to the internal surface of the voltage gated sodium channel and keeping them at inactive state. How do they block this? They keeping it at the inactivated state, means they are keeping the voltage gated sodium channel at this phase, the inactivated phase. So the picture. They are keeping it at the inactivated state, so no more nerve conduction can occur. It means no more pain transmission can occur. That's how local anesthetic works. They prevent further nerve conduction by keeping the voltage gated sodium channel at the inactivated state, where they are not capable of opening anymore. Okay, that is the first theory, which is the most common and most accepted theory. The second one, which is a possible theory, is the membrane expansion theory, in which what they say, the unionized form diffuse into the cell membrane. They don't go into the cytoplasm. They just go into the cell membrane, and then they cause swelling of the voltage gated sodium channel or the lipoprotein matrix. They cause some conformational changes in this phospholipid membrane, which alter the conformation of the voltage gated sodium channel, which is also called the swelling of the sodium channel, and that causes the inactivation of the voltage gated sodium channel. So these are the two types of theory that exist regarding the LA mechanism of action. So again, repetition, if you look into it, I want to talk about the ionized form and non-ionized form. When you give your LA, you inject your LA, this is the non-ionized form which has to cross, and in the cytoplasm, it get protonated and become ionized form, and this ionized form will bind to the internal surface where the inactivation gate is there. Your activation gate is outside, external. Your internal part has the inactivation gate. So it go and blocks this inactivation gate and keeping it in the inactivated state. It keeps in this state. Okay. So this part has been blocked. So this part is always closed, which maintain them in the inactivated state. So this is just another way of looking at it. So lignocaine, it diffused through the cell membrane, but here you have to mention lipid soluble unionized form, binds to the voltage gated sodium channel internally once they get. So this, if you answer it like this, what I mentioned here, if you answer it like this in your SAQ, you won't get full marks because you are missing the keyword. How do they diffuse through the cell membrane? You have to mention the unionized lipid soluble form. Which part binds to the voltage gated sodium channel is the ionized form. Okay, which binds to the voltage gated sodium channel internally at the cytoplasm, not externally. They bind to the inactivation gate site intracellularly. Okay, and then blocks the sodium entry into the channel. How? When the sodium entry into the channel is blocked, there are few things will happen. We come into this, and that causes the slowing of nerve conduction. So what factors affects this sodium channel blockade? It means what are the factors that affect the local anesthetic action at the sodium channel that causes the blockade? So this is where the few terms comes in which involve this different state of sodium channels. First, rate of firing of neuron, frequency dependent. If the nerve is very frequently firing, it means it is moving from activation to inactivation to rest, that LA will most likely will go and block that nerve first, because they are more attracted or more affinity towards activated and resting state rather than the activated and open inactivated state rather than the resting state. Okay, so that is the rate of firing of neuron is frequency dependent. Okay, that is about the frequency dependent, as in they are more their affinity is more towards the activated state of the sodium channel. Type of nerve, this is velocity dependent. If the nerve is myelinated or unmyelinated or small or large, so this what we define as the velocity dependent or the nerve diameter dependent. Okay, this will tell you about the differential blockade of the LA. Why there will be a difference in block in proprioception or autonomic symptoms or pain and touch sensation when we give LA. This is because of the type of the nerve. This causes a differential blockade. It is velocity or diameter dependent because your diameter of the nerve determines your velocity. Okay. Next would be concentration dependent, which is based on all these things. So it's of course what affects your LA action. If you give in a larger amount or large concentration is present nearby the nerve, of course the blockade will be more faster or more profound. So what are the things that affect the concentration of an LA which is given at a same dose? It is rate of the systemic uptake. It means where do we inject it, the site of infiltration, the drug pKa, lipid solubility and protein binding of the individual LA, drug intrinsic vasodilator activity, which causes dispersion of the LA from the site of the injection, or the additive, the adjuvants that we put in to improve the action. So this is concentration dependent. So the reason why I talked about the resting state, activated state and inactivated state is to mention about this frequency dependent part. Okay, the degree of blockade is proportional to the rate of stimulation due to the attraction of the local anesthetic to the open sodium channel, which is the activated state. Next, we come into the differential blockade. So this is what I mentioned about the nerve diameter and velocity. When a nerve is bigger, their conduction velocity is faster. You can see bigger diameter, faster velocity. Slower diameter, slower velocity. So the blockade of when we give LA, the blockade of the nerve also based on this. The nerve that is bigger, a larger diameter or have a higher conduction velocity will be the slowest to be blocked by the local anesthetic. Whereas the nerve fibers which is smaller or which has the lowest conduction velocity will be the fastest to be blocked by the local anesthetic. So it's kind of common sense. When the nerve is small, it's easier to block. So you can remember in that sense. Okay, so but I want to ask this question. So we can look at it, B fiber and C fiber. We have B fiber, which is larger in diameter, have a faster conduction velocity, but C fibers, which is smaller in diameter and slower conduction velocity. But when you give spinal anesthesia, before the patient actually feel the loss of pain and temperature, you can see patient already started developing hypotension, vasodilation, autonomic symptoms lah. Okay, sympathetic blockade, they have vasodilatation. It means the B fibers, which is preganglionic autonomic fibers, are being blocked first before the C fibers. Why is that so? Because biologically, when we are talking, diameter, which is smaller, should be blocked first. However, the B fibers are getting blocked first. That's why in spinal anesthesia, we get hypotension, the secondary to vasodilatation first, before patient actually can have a complete blockade of the pain and touch and temperature sensation. This is because of the myelination. You can see B and C fibers, even though the C fibers are small, but they don't have myelin. Whereas when the B fibers bigger, they have myelin. So what is myelin? Myelin causes increase in conduction velocity, or what we call as the, and what is another one is the nodes of Ranvier, which is called saltatory conduction. So this causes the frequency dependent, what I mentioned just now. So when this firing is more because of this myelination, your LAs are more attracted towards there, even though their size of diameters are different. That's why in spinal anesthesia, you get differential blockade, you get a B fibers being blocked first before the C fibers, despite C fibers being small. Okay, so the conduction blockade. So now we already understand how does the LA go and blocks the voltage gated sodium channel and what are the factors that affecting it. So by blocking the voltage gated sodium channel internally and keeping it inactive state, what does it do to the action potential? So what happened to the action potential? First, the excitation of firing threshold increases. The firing threshold is the minus 50 millivolt. From minus 70, if it slowly reaches minus 50, the depolarization occurs. But what does the LA do? It increases it from minus 50 to even higher, maybe minus 20 or minus 10. So it takes a longer time from minus 70 to reach a minus 20. So it increases the firing threshold. Thus, it reduces the likelihood of the nerve to get depolarized. Next, abolish the ability to generate action potential. By keeping them in the inactive state, no more sodium can influx. It means the voltage gated sodium channel is incapable of opening and generating another action potential. The peak and rate of rise of the action potential amplitude decrease. Whichever the nerve that already depolarizing, by blocking the other sodium channel, less influx of sodium, thus the amplitude, the rise of the depolarization phase might not reach up to the positive 30 millivolt. They might only reach up to 20 millivolt. That's the conduction. Just the impulse conduction is not complete. Slows nerve impulse conduction. By doing all these things, they slows the nerve pulse conduction. And of course, the refractory period is lengthened. The refractory period is the part where the voltage gated sodium channel is in the inactivated state. So this is a summary of all these things. I will share this so you can see this. I saw a nice flyer, I think under Nysora when I'm reading about regional anesthetic. So the thing that I want to show here is this graph. You can see without the local anesthetic, here they mention as minus 90 lah, but usually for Exxon is in our book we use it as minus 70. Minus 90 is for cardiac action potential actually. So it's minus 70. So without the LA, from the minus 70, when it reaches around minus 50, here just take it as 70 and 50. Yeah? It actually depolarized and reaches around positive 30 and comes down. But with LA, you can see it does not achieve the action potential. The action potential is not being generated. It's still below the threshold potential because the threshold potential is unable to achieve. Thus, no depolarization and action potential propagation occurs. Okay, next we come to the concept of pharmacokinetics for LA as an overview. We are not going to the individual LA. So when we talk about pharmacokinetic, we are talking about absorption, distribution, metabolism, and excretion, ADME. So absorption, we're going to compare whenever we talk about absorption is IV versus non-IV. Of course, IV will be 100% lah, most to 100%. So when we talk about LA absorption, we are not talking about the IV routes, we are talking about the non-IV routes. Okay, when we inject in other sites apart from IV, how does the absorption? So it depends on the site of the injection, which based on the tissue vascularity. So when you inject at these places, from these places, what are the places that likelihood to reaches the highest systemic concentration? When you inject at the leg, at the thigh, how fast it can actually go into the systemic circulation. Okay, so this is the highest versus systemic. The highest will be intercostal, caudal, epidural, brachial plexus, and finally is your subcutaneous. It means when we inject subcutaneously, let's say you're injecting around a lipoma in your hand before a simple LA surgery, and that will be subcutaneous. That will be the lowest. Next will be the brachial plexus. From epidural, it can actually reach a higher systemic component moderately. Caudal, yes, even faster because of the high vascularity of your caudal area and sacral area. And then finally is your intercostal nerve. Okay, intercostal nerves, if you are injecting your intercostal block, around there are neurovascular bundle, which is very potential to reach high systemic concentration and develop local anesthetic toxicity. Okay, you have to know this. Okay, next, the rate of injection. Of course, if you are injecting in a very fast manner, so it can seep through the membrane and reaches the vessel. Dosage, that is why we calculate the dosage. And then finally, the vasoconstrictor additive. If you are adding a vasoconstrictor, that is why the local anesthetic doses differ with and without adrenaline. Either you are giving a bupivacaine or you are giving a lignocaine, the dose differ, because when you add on a vasoconstrictor, you tend to keep the local anesthetic at the localized area of injection. Because the vessels are vasoconstricted, though the less absorption from the local injection to the vessel. So that is the role of vasoconstrictor. We will talk about the vasoconstrictors and types and how they work in our adjuvants in second topic. So next, distribution. Pharmacokinetic distribution is first factor is the protein binding. One of the first few slides, I talk about amide versus Fester. So it's bupi, ropi, and lignocaine. So highest protein binding would be bupivacaine, followed by ropivacaine, followed by lignocaine. So when a drug is being distributed highly because of protein binding, it means there is no free form available. That is why they cannot be metabolized fast. Their duration of action also longer. So your protein binding closely relates with your duration of action. That's why bupivacaine duration of action is high. Second will be ropi, and the shortest duration of action will be lignocaine in amides. But overall, amide versus ester, amides have a higher protein binding, thus longer duration of action compared to esters. Next, again, regional blood flow, vascularity. Let's say we inject LA at the level of this part compared to these two areas. Whenever there is an area with high vascularity, it will be easily absorbed into systemic circulation and it get dispersed. Okay, it means it lost from the area of interest and it goes into systemic circulation. And once in the systemic circulation, it goes through your pulmonary circulation, and these drugs are being extracted in your lungs as well. So thus, this is the distribution. They goes into the pulmonary circulation as well. Lignocaine, bupivacaine, and prilocaine. Okay, remember this for your SBA. And another thing about placental transfer, your LAs actually can cross blood-brain barrier because they are weak bases. They are lipophilic, so they can cross blood-brain barriers and placenta as well. So again, they are influenced by the protein binding. Those with the low protein binding can easily cross across the placenta, whereas the one with the high protein binding like bupivacaine have the lowest. Compare dengan ester dengan amide, esters are rapidly metabolized by the plasma cholinesterases. So thus, they have almost nil transfer in placenta. Amides, they do get transfer across the placenta. This is the concept of that. That's why there is concept or risk of ion trapping in fetal acidosis. Okay, we come back to here, this place. What is ion trapping? I've mentioned to you, when we inject an LA, it go across the phospholipid membrane and we get protonated here. Okay, the protonation or ionization in the exoplasm is closely related to your pH and pKa. Okay, pH and pKa. We're coming to this part. When it close to pH, means your pKa is closer to pH of the environment. It means they are more unionized. Mean they can easily move around. Unionized is lipid soluble. When they are far deviated from the environmental pH, they are more in ionized portion. Thus, they cannot move around freely. Okay, what happens in fetal acidosis? Okay, we give a patient spinal now. Okay, let's say we give spinal, there is LA. So LA gets seeps through and goes across the placenta. At that patient, at the maternal circulation, maternal pH is 7.4. Mother is not acidotic. Okay, so they are still exist more, can present in a unionized form, or which is lipid soluble, they can cross across. But when it reaches the fetal circulation, when a fetal in a fetal distress or fetal bradycardia, fetal acidosis, the fetal blood circulation environment is more acidic. It means it's lower than 7.4. The pH of the fetal circulation is lower than 7.4. It could be 7.2 or 7.1. Whereas the pKa is still the same. Let's say we give a pKa of lignocaine. In spinal we give bupivacaine, right? So the pKa is 8.1 for bupivacaine. In a maternal circulation, 8.1 minus 7.4 is 0.7 only. Whereas in fetal circulation, if it's 7.2 pH, 8.1 minus 7.2 is 0.9. So it's more, the difference is bigger. So they are present more in the ionized form and they get trapped. They cannot come out from the fetus. So that is what called the risk of ion trapping. So when they get trapped in the fetal circulation, they can cause more harm. They can cause toxicity. So that is what understand by ion trapping. We'll come into this when we talk about ionization pK again. Pharmacokinetic metabolism and excretion, we're going to talk about ester versus amide. In ester, we mentioned earlier, they are rapidly hydrolyzed by pseudocholinesterases. So they are metabolite, produce a metabolite called PABA, para-aminobenzoic acid, which has the allergic potential. Okay, this ring. This is your aromatic ring. This is your intermediate linkage of your ester. At this aromatic ring, and the first component of the intermediate linkage in ester is what responsible to produce this metabolite called PABA, which has the allergic potential. All the esters undergo rapid hydrolysis by pseudocholinesterases except cocaine, which undergo hepatic hydrolysis like amide. Okay, amide undergoes hepatic metabolism by amidases. Mostly have not a very significant metabolite except for prelocaine. Prelocaine have metabolite called O-colloidine. Prelocaine is used in we use prelocaine for EMLA. Okay, so that's why we need to know about this O-colloidine, which can cause methemoglobinemia, especially in susceptibles like infants who doesn't have a methemoglobin reductase enzyme. We'll come into that when we talk about EMLA. Next, lignocaine as a metabolite also. It's an active metabolite which also has an antiarrhythmic property. So just remember this part. For excretion, all of them get excreted in urine lah. Okay, just need to know that much is enough about excretion. Nothing much special about excretion for LA. But for metabolism, you must understand hepatic metabolism. What we have to know is the issue is the liver. Okay, since patient it's a highly hepatic metabolism for amide LAs, patient with liver derangement, you need to give a reduction in dose. And since they are get excreted in urine, and I mentioned amide has a tendency to get accumulate and cause toxicity, systemic toxicity. Thus, it also in ESRF patient everything, we reduce the dose of LA for especially for infusions or peripheral nerve blockade infusion and so and so. Next, we talk about pharmacodynamic. Pharmacodynamic is all about dose versus effect. Okay, when we give a certain dose of a drug, what does the effect that we see? And what are the factors or what are the situation reasons that affect this dose effect relationship? So the dose that we remember or we seen previously, okay, this also has some discrepancy from book to book. Okay, lidocaine without epinephrine, this is without adrenaline and this is with adrenaline. They say 5 mg per kg. Bupivacaine is 2.5 mg per kg. Just ignore this mepivacaine. We are not using it. Ropivacaine is 3 mg per kg. But what I remember lidocaine as 4, ropivacaine as 3, and bupivacaine as 2. So 2, 3, 4. BPL. I remember as BPL. Bupivacaine is 2, ropivacaine is 3, lignocaine is 4. You can remember this. This is acceptable. Okay, 2, 3, 4. 2 for bupivacaine, ropivacaine is 3, lignocaine is 4. With addition of lignocaine, with the addition of epinephrine or adrenaline, the lignocaine can be given up to 7 mg per kg. Bupivacaine can go up to 3 mg per kg. Just now I mentioned here 2, right? So it can go up to 3 mg per kg. And ropivacaine, there is no, we usually commonly, you say you add marcaine and adrenaline when surgeon want to infuse. You want to inject LA, sometimes we infuse with lignocaine and adrenaline. But have you all ever practiced adding adrenaline to ropivacaine? It's not a practice, right? Why? We can add adrenaline to ropivacaine and make it 4 mg per kg, right? It's not done commonly. Why is it so? We'll come into the discussion soon. Okay, so the pharmacodynamic properties. So we have talked about the dose. So what are the dose do to the body? So how do they affect? It's all based on their potency, the duration of action, onset of action, vasodilator activity, and toxicity. So how do we want to know all this? It all closely related to the structure activity relationship. How does the structure of this LA actually affect their physical and physicochemical properties and pharmacodynamics? So this is the structure of lignocaine in full, but you don't have to know this. You can just remember the aromatic ring, the amide group, and the terminal amine group and the intermediate amide linkage. So structural activity relationship. This is the structure. We are recapping your lipophilic aromatic ring, hydrophilic terminal amine, and intermediate chain which has ester and amide. From here, we will look into it how each component or each section of it affects the activity of the LA. So first, molecular weight. By adjusting or substituting a certain component in the aromatic ring or intermediate linkage or the terminal amine, we are actually disturbing or altering the molecular weight of the substance itself. So by altering the molecular weight, we will get a different chemical or different property of that agent. So this molecular weight is affected by first the aromatic ring. When you add on more 3 or 4 carbons or substituents, they increase the molecular weight. What happens is, you see this part. If there is an aromatic ring at the position of 3 or 4 carbon, if you want to add more, okay, if you're adding in more component to it, it will add the molecular weight. In your current level, you don't have to remember what are the things being added. I will give the example soon. But if you see what I'm mentioning at aromatic ring, more 3 to 4 carbons or substituents over here means I'm talking about this part. Okay, this will increase the molecular weight of the LA. Second, intermediate chain. Intermediate chain length. If the length is, this is the intermediate chain. If the length is even longer, especially for esters, we are talking, it will increase the molecular weight of the LA. Next, the amino group branching and more 3 or 4 carbon will causes increase in molecular weight. Like converting the 3rd and 4th carbon, it will become methyl to ethyl to butyl. We're looking at this is the mepivacaine. This is your different group here. Your bupivacaine, your different group here. This slide, I just want to show you what increases the molecular weight? We will go into the example after this in detail. So the alteration in molecular weight can happen at the aromatic ring, at the intermediate chain, and also at the amino group. Okay, at the amino group is the conversion from methyl, ethyl, and butyl. So what does this increase in molecular weight do? When there is an increase in molecular weight, they are increasing the potency of the LA. Okay, the LA with a higher molecular weight mean high ring, high component, high side chain, have more side chains and everything. They are increased in molecular weight. They increases the potency. When the potency is increased, there's always the risk of toxicity. Okay, that is why the bupivacaine molecular weight, the side chains are more compared to lignocaine. That is why bupivacaine is more potent. That's why you only have to give 2 mg per kilogram, whereas lignocaine is less potent. That's why you have to give 4 mg per kilogram to achieve the same effect. But bupivacaine, since they are very potent, they have risk of toxicity more than lignocaine. If you give bupivacaine 4 mg per kilogram like lignocaine, the toxicity will come in. That's why you have to reduce the dose. Okay. Next, the increase in molecular weight also affects your lipid solubility. Higher molecular weight, higher lipid solubility. Higher lipid solubility means it can go across the exoplasm very fast and it can cause more action. It means they are highly potent. Again, bupivacaine versus lignocaine. Bupivacaine is highly soluble compared to lignocaine. Okay, that is the reason why they can cause cardiac toxicity. They can cross across, they can bind, and then they can bind to your cardiac myocytes. Okay, their lipid solubility is higher compared to lignocaine. And the lipid solubility again goes back to your potency and duration of action as well. Okay, they are highly lipid soluble. They can stay in your body longer. Next, increase in protein binding. Increase in molecular weight also as a determinant for the protein binding of that substance, the LA. But protein binding increases the duration of action, but they slows down the onset of action. So they have a good thing, they can increase the duration of action, but they slowing the onset of action. So increase in molecular weight, it increases your potency, right? It increases your duration of action, but it slows your onset of action. So just look at this example. So first I'm showing you mepivacaine versus bupivacaine. Okay, this is the methyl group, this is the butyl group. By changing the methyl group, so other things are exactly same. You look at bupivacaine and mepivacaine, looks exactly same except this side chain. By changing this methyl group to butyl group, this is the methyl group to butyl group, mepivacaine become bupivacaine. Their solubility increase, lipid solubility 1 become 20 to 26 lah. Some book mentioned 26. I think I got this from, don't know which, but you can see it significantly increased. So, and also the duration of action. Mepivacaine only 100 minutes, but bupivacaine is 175 minutes. Mean this molecular weight has improved. From CH3 it becomes C4H9. It means this molecular weight is higher, thus duration of action is increased, protein binding is higher, and lipid solubility is higher. So they have higher potency, longer duration of action. Okay. Compare ROPI and BUPI. C3H7, C4H9. Obviously, this is smaller side chain compared to this, right? That's why you see duration is shorter and lipid solubility is lower. So less potent compared to this. Then we compare lignocaine. Lignocaine side chain as well, C2H5, C2H5, but their side chain is here, is divided into 2. That is why the difference. And then next, we look at shortening of butyl group to propyl group. This is bupivacaine to ropivacaine lah. So this is the butyl group. If shortened to propyl group, the lipid solubility reduce 3 kali ganda. Okay, there's 20 to 7. So this is some example of we looking at how does the change in the individual side chain of LA actually affect their protein binding, duration of action, potency, and onset of action as well. So this is the structural activity relationship as overall. So summary. So in the exam, if they ask you, list the factors that affect the potency of the local anesthetic. Number 1, you'll mention about the lipid solubility. Okay, the smaller the molecule or more lipophilic the molecule, it can easily cross the membrane or phospholipid membrane. and cause the effect once they get protonated lah. And vasodilator property, the intrinsic vasodilator property of that drug that we are talking. If the drug has more vasodilator property, all the LAs possess intrinsic vasodilator property. I will come into that in detail. Just remember this sentence now. All of them possess intrinsic vasodilator property, meaning when you inject, they causes vasodilatation at the site of injection, which is for them is a disadvantage. They are dispersing their LA from the site of the injection. So the more the vasodilator property of the LA, the less the potency. Higher lipid solubility, higher potency. Higher vasodilator property, lower potency. And tissue distribution. Tissue distribution is in as a which is related to the protein binding. Higher protein binding, it means patient have longer duration of action. So that also affects your potency as well. Next, duration of action. What are the factors that affect the duration of action? Obviously, protein binding, the dose that been given. Okay, if you're given a very high dose, it get compounded and it get accumulated with the metabolite, so duration of action can be more. The lipid solubility, the blood flow at the region that we inject, and plasma versus tissue concentration. These are the factors that affect your duration of action. And we come into the concept of intrinsic vasodilator property. As I mentioned, all the LAs causes vasodilatation in low dose, especially we are talking about amides that we use lah. So amides causes, all these are amides, okay, prelocaine, lignocaine, all got double I, right? So all are amides. So all causes vasodilatation in low dose, but when you give in high dose, they causes vasoconstriction at higher dose, except cocaine. Cocaine is solely vasoconstricted. Why? They have this extra effect of inhibiting neuronal reuptake of catecholamine, which is norepinephrine, and inhibiting monoamine oxidase. Monoamine oxidase is the enzyme that metabolizes your catecholamine. So by keeping a norepinephrine high in your circulation, because it inhibits the neuronal uptake, means circulation as norepinephrine, supposedly it get reuptake into the neurons, but this cocaine is inhibiting it, so keeping it in the circulation. And in the circulation, the catecholamine can be metabolized by MAO, but cocaine inhibit the MAO, thus keeping it noradrenaline higher or catecholamine higher, making a vasoconstrictor property. That is the use of cocaine in Moffat solution. Moffat solution used in ENT surgeries, and also when we want to do awake fiber optic, we spray this Moffat solution into our nostrils to vasoconstrict and also numb. You get two effects. One is local anesthetic effect and also the vasoconstriction. So when we do awake fiber optic, patient will not feel pain and also less risk of causing bleeding, epistaxis. Okay, that is the use of PEG. Okay, just now I've mentioned here why ropivacaine is not being added with epinephrine. Lidocaine, bupivacaine all got addition with epinephrine and changes in dose, but ropivacaine does not do that because at this slide we can see among all the drugs, all the LAs that have vasodilator property, ropivacaine has the least vasodilator property. It means it causes the least vasodilatation. In other words, ropivacaine actually more towards vasoconstriction compared to vasodilatation, whereas lignocaine, bupivacaine all more vasodilatation. Ropivacaine causes the least vasodilatation. So it does not need an additional vasoconstrictor to aid, to help to stay in that region. And when a study done, experiments done, ropivacaine alone versus ropivacaine versus epinephrine, the duration of action is unchanged. So that is why we are not adding adrenaline to ropivacaine, because ropivacaine has the least vasodilatory property. So it themselves, they can contain their drugs in the region without addition of any vasoconstrictor. So that is the reason why ropivacaine is not added with any adrenaline. Next, onset of action. Onset of action, of course, depends on the site or route of administration where it is being given. You inject at skin versus you inject into spinal. So difference, right? When you give spinal, within 2-3 minutes, you see the effect. but you inject it topically, it takes longer time. So the route of administration, the site of administration plays a role for onset of action. Drug pKa, the lower the pKa at physiological pH is more ionized. Lower means it's nearer to the pH of 7.4 compared to lignocaine and bupivacaine. Bupivacaine have a pKa of 8.1, whereas lignocaine have a pKa of 7.9. So 7.9 to 7.4 or 7.4 to 8.4 bupivacaine. The difference between 7.9 to 7.4 is 0.5 for lignocaine, which is closer. That is why the onset is faster. Okay, we will discuss this more in the next lecture when we talk about the graph of ionization. Drug lipid solubility, okay, that also plays a important role. Next, tissue inflammation affects the ionization. This is the reason why we say LA doesn't work in acidic environment. Same concept as the fetal ion trapping and everything. In an acidic environment, because of the environmental pH is lower than 7.4, the differences between pKa and the environmental pH become bigger. Thus, the LA become present in more in ionized form. They cannot penetrate through the phospholipid membrane to exert their effect. That is why when patient have abscess, when they want to do under LA and everything, we can't. They say LA doesn't work. So there is adjuvant. That comes to the play a role of adjuvant. We give sodium bicarb. So what they do, they inject sodium bicarb around the abscess first to alkalinize the environment, to bring up the pH more than 7.4, closer to 7.4. Then you inject LA. So that is like you are going reverse lah. Okay, you are bringing up the pH and then you inject LA. So the gap is being closed. Okay, the pKa is the important. So the concept of pKa, you can see it comes into many areas. That is why I want to go through it detail, and you have to understand the pKa for weak acid and weak bases and the Anderson-Hasselbalch equation. So that brings us to the topic of ionization pKa, which will be dealt in the next topic. So the next topic, I will start off with Anderson-Hasselbalch equation, where we will go into few calculation for weak acid and weak base. And then we will talk about how does the onset. You can see the onset for lignocaine, bupivacaine, chirocaine, chloroprocaine and procaine. How does it differ? Because the pKa is higher. So their onset is slower. They are far from the physiological pH. And then we compare here as well, the ionization and everything. So this will be dealt in the next class. Okay, that's all for today.